Good evening, everybody. Assalamu alaikum and welcome. Greetings. Welcome to our monthly webinar hosted by the Institute of Public Health. My name is Dr. Azhar, and if you know that I am the coordinators of the webinars in the Institute of Public Health, so I usually attend all the webinars and be behind the scenes. So I'm so happy today that I'm attending in front, so I had the chance to speak to all of you. The webinar, as you all know by now, is a part of an initiatives that called Public Health, which is a global initiative. It aims to shed the light at various critical public health issues. We are honored in the Institute of Public Health to be affiliated with ASFER, the Associations of Schools of Public Health in the European region, and the IFA, which is the Emirates Public Health Associations. And it brings me great pleasure to announce that the United Arab Emirates had accredited our webinars with one CME Category 1. So as usual, we will go through some housekeeping. Throughout the webinar, you are encouraged to ask questions. So please, you can click on the question answer options in the middle bottom of your screen, and we are going to answer all your questions at the end of the presentations. However, during the presentations, our esteemed speakers is going to ask some questions for the engagement. So please put the answers to these questions in the chat, and I will be reading it to the speakers. Note that this webinar is actually recorded. Therefore, it will be uploaded on our YouTube channel. And at the end of the webinar, we are going to share a link in the chat for the evaluation of the webinar. So make sure that you fill these evaluations in order to obtain your CME certificate. It gives me great pleasure to introduce our esteemed speakers today, Dr. Ashwin Kotwal. Dr. Ashwin is an assistant professor of medicine in the Division of Geriatrics at the University of California, San Francisco School of Medicine. He completed undergraduate training in anthropology at Northwestern University and has medical and biostatistic training at the University of Chicago. He went to complete his internal medicine residency at Harvard University, and he is an integrated clinical fellowship in geriatric and palliative care at UCSF. Dr. Kotwal devotes most of his time to research focusing on understanding and enhancing social connections of older adults to improve their quality of life and healthcare access. He has received funding from the U.S. National Institute on Aging to investigate experience of loneliness and social isolations among older adults with cognitive impairment and the impact of COVID-19 on the social well-being. His research interests also involve evaluations of community-based intervention to address loneliness and isolations, particularly among older adults with cognitive impairments or approaching end of life. His clinical practice is at the San Francisco Veteran Administration Medical Center. He is an associate director of the UCSF Division of Geriatric NIH-funded T32 Aging Research Fellowship and has a strong interest in mentorship. So without further ado, I would really honor to ask Dr. Kotwal to share his screen and to enlighten us about an interesting and very important topic, which is the loneliness and social isolations among older adults and emerging public health challenge. Dr. Kotwal, the virtual floor is yours.
Great. Thank you so much for the very kind introduction. And I'm so excited to be here. I have my coffee because it's morning here in the States, and I hope you all have your evening tea or whatever drink you need to get through this. So I'm going to share my screen, and we can get started. All right, so let's see, we got this here, and then let me start the slideshow. Okay. All right, can you all see that okay? Great, I'm seeing.
Yes, we can. Thank you so much. We can start.
Perfect. All right, so today we'll be talking about loneliness and social isolation among older adults as an emerging public health challenge. And I'm going to be focused mostly on data here in the United States, but I'm very interested in everyone's thoughts about this topic as a global issue, including in the UAE or elsewhere where you might be calling in from. Because, you know, as an emerging public health issue, we're still gathering data. We're still trying to figure out how best to make an impact on from a public health standpoint. I'm also a clinician, so much of the way I discuss things will be from a clinical viewpoint and perspective, and you know, interested in thinking about this across many disciplines. Okay, so here are my disclosures. I have a couple of commercial sources that are not relevant to today's talk, and I also have funding from the National Institute on Aging, the California Department of Public Health, and the National Palliative Care Research Center. So here are the learning objectives for today. We have 3. The first is to think about how are loneliness and social isolation defined and what are their health effects. The second is we'll think about experiences of loneliness and social isolation among older adults affected by serious illness. And this is really guided by my clinical background in palliative care, serving older adults at the VA, the Veterans Affairs Hospital here in the US. And the third is we'll think about how to support older adults experiencing loneliness and social isolation. And I'll apply a clinical framework for interventions in a clinical setting. And we can also think about public health interventions as well. Okay, so our first objective are definitions. So here are a collection of headlines actually from before the pandemic, where loneliness and social isolation were described in pretty dire terms. Loneliness was described as an epidemic. Social isolation was described as killing us, and that it was deadly. And it was really clear even before the pandemic that people really cared about their social connections and how it was impacting people's health. And several decades of research started to draw attention to this issue, showing that it was related to increased disease risk, mortality, and people's quality of life. Some countries started to take note of this. Notably in the UK, they developed a minister of loneliness. Similarly, they had a minister of loneliness in Japan. Increasing attention started to be placed on this issue in the United States as well. Our US Surgeon General, Vivek Murthy, has made this kind of his primary topic of interest. I became interested in this topic during my Geriatrics and Palliative Care Fellowship. As I was caring for older adults, I noticed that loneliness and isolation were really a fundamental source of suffering as people aged and as people approached the end of life. I learned a lot about how to provide good medical care for people in those really critical moments, but I had a hard time understanding how to integrate people's social needs into their clinical care. And I wondered a lot about this disconnect between people's, the general public's interest in their social connections and the lack of prioritization that we often place on these issues in a clinical field. And so I started to investigate how we might address these issues. And when I first started reading about these topics, I got a little lost in the literature. You know, after decades of research, there are so many different terms that describe social connection. And, you know, it can make anybody a little bit nervous to figure out where to start here. And so social isolation and loneliness have actually emerged as kind of central terms that are used to describe people's overall social life. Loneliness being the subjective assessment that social relationships are lacking, and social isolation being the objective measure of connections to friends, family, or the community. And you can see in the Venn diagram that they are related, but they're relatively distinct concepts. And we'll be discussing these today as kind of major markers of people's social well-being that we can assess both from a public health standpoint as well as a clinical standpoint. And this fits within a broader framework of social connection, where we go all the way from subjective or functional assessments of social connection, like loneliness, all the way to these objective or structural assessments of people's social connections, like social isolation, social support being a little bit in the middle, and a very commonly used term as well. I encourage people to take a look at the citation on the bottom here by Dr. Julianne Holt-Lundstad, which really nicely describes these definitions in the context of public health. For me, it's most helpful to ground some of these definitions and these terms in people that I see in clinic every day. So here's one person who I've modified some of the details and the names to preserve confidentiality, but may resonate for people in the audience in terms of highlighting these issues of loneliness and isolation. So this is Mr. Smith. He's an 84-year-old veteran with mild cognitive impairment. He has moderate chronic obstructive pulmonary disease, and he has recently diagnosed metastatic colon cancer. And I remember seeing him in my palliative care clinic over at the VA. He had recently been started on FOLFOX therapy, which is a chemotherapeutic agent for colon cancer. And he presents today after he missed an appointment a few weeks ago. He's alone and he hasn't told anyone else about his diagnosis. He fortunately doesn't have any chemotherapy-induced symptoms, and he scores negative for depression and the PHQ-2 depression screener. We also note that he has no advance directive on file or a designated power of attorney to help make medical decisions if he were unable to do so himself. So the question is Mr. Smith lonely? And feel free to put this into the chat, yes or no. And also, maybe start thinking, have you seen situations like this in the UAE or in other global contexts? Does this sound like a situation that's more unique to the US, or can you relate? So trying to get at loneliness, it's important to get back to what are we actually talking about here? How do we define loneliness? So loneliness is the subjective feeling of being alone, or the distress that results from discrepancies between ideal and perceived social relationships. So this is that feeling of lacking companionship, feeling alone, feeling like you're left out. Importantly, you can feel lonely in a crowd. So many people can be surrounded by different social relationships, their children, their family, their friends, but still feel lonely. When I think about how to assess this in a clinical setting or in a public health setting, I usually try to keep it simple and just directly ask people, how often do you feel lonely? Is it some of the time or rarely? Is it most of the time? Is it often or always? Just starting there can help you get a sense of what's going on. There's also much more lengthy and complicated scales. And in between is this 3-item UCLA loneliness scale, which asks people if they feel left out, feel isolated, or lack companionship. It's graded on a 0 to 6-point scale with 1 point or higher representing sometimes lonely, and 4 points or higher representing always or often lonely. So how common is loneliness? Most of the data is from the United States or Western European countries. In the United States, for example, it's common across the lifespan, with about a third of individuals at any point in their lifespan experiencing at least occasional loneliness. In the UK, some data suggests that about 1 in 10 people feel frequently lonely. So they're responding, that they're often lonely to that 3-item scale. And we found that this increased dramatically during the pandemic. So if you all can think back to early on in the pandemic when we were all told to stay at home, we were, by definition, we were isolated from others, and that impacted people's feelings of loneliness quite a bit. Here's some of the work that we did during the pandemic, showing experiences of loneliness over about the first 18 months in the Chicago area, so in the central United States. When we followed about 700 older adults, we found that there were 4 different trajectories of loneliness. And these are shown in 4 different colors. For some people, they were lonely throughout the pandemic because of the shelter-in-place restrictions. That's shown in the green bar. That affected about 1 in 6 individuals. In contrast, about 1 in 5 people adapted to pandemic restrictions, shown in the blue bar. Some people were just occasionally lonely, shown in the red bar, and some people were really never lonely. They weren't really affected by pandemic restrictions in that way, and that was about 1/3 of the people shown in our sample. These data are fairly consistent with other national estimates in the United States. And what we found was that people who were at risk of persistent loneliness were those living in poverty, people who were living alone, people who had trouble with technology to connect with their friends and family, and people who were previously anxious or depressed. So what might be going on elsewhere in the world? This is, as I've mentioned before, an emerging topic area. And so we're still gathering data around loneliness in different cultural and global contexts. Here's one study that was recently published in the British Medical Journal in 2022, which just tries to find where is there data globally on loneliness and social isolation across different life stages. And so countries that are highlighted in the dark purple are places where there is data on loneliness. And so you can see for adolescents, shown in the upper left, younger adults shown in the upper right, middle-aged adults in the bottom left, and older adults in the bottom right. So in general, we have the most data on older adults kind of throughout the world. And when we zoom in on the peninsula here, we can see that there's actually very little data in much of this space, whether it's Africa or the peninsula, or even in some areas of Western Asia. And so there's very little that's actually known here, but what we know from the countries where we do have data is that about 10 to 20% of people globally report frequent loneliness, and that about 1 in 5 people report social isolation. Okay, so why should we care about this? Here is one of the most highly cited studies in the medical world published by my colleagues, Dr. Personotto, Sensor, and Dr. Kavinsky. This was published in JAMA Internal Medicine in 2012. They followed about 1,600 older adults over 60 years old for 6 years, and they asked if they were lonely using that UCLA loneliness scale that I just showed. What they found was that loneliness was really common, about 40% of older adults. This was even common among married individuals, which kind of challenged some assumptions. About 2/3 of married individuals reported feeling lonely, and only about 25% of individuals living alone were lonely. So even though people are living alone, doesn't necessarily mean they're lonely. When they followed them for 6 years, they found that they had much worse health outcomes. They had a higher risk of premature death, so 23% versus 14%, and a higher risk of ADL impairments, or development of functional disability, about 25% versus 13%. So this was really shocking to much of the medical community because many of us had not really integrated loneliness into our clinical management. Now, since then, there's been really an explosion of research on loneliness showing that it's deeply related to many different health outcomes. So here's some work that demonstrated that lonely older adults experience higher rates of symptoms, including pain, anxiety, depression, and fatigue, as well as the cluster of these symptoms. This is work conducted by Dr. Powell out of University of Michigan. And some of our work has shown that lonely older adults also have more uptake of high-risk medication use related to these symptoms. And that includes NSAIDs, antidepressants, anxiolytics and sedatives, benzodiazepines, opioids, and polypharmacy, or 5 or more medications overall. And so taken together, we're starting to put together some of the health mechanisms by which loneliness impacts many of these different outcomes. one of the core reasons we think loneliness impacts our health is through emotional distress, right? Loneliness by definition is emotionally distressing. And when we experience that over many years, that can lead to a stress response. That can disrupt our sleep. It can cause disruptions to our motor function, and in general leads to a wear and tear on our body over time. The second major mechanism is through health behaviors and the receipt of medical care. So lonely older adults may have different patterns of health behaviors or the receipt of medical care that eventually affects their downstream outcomes. Okay, so coming back to our case, Mr. Smith, our 84-year-old who has metastatic colon cancer, we administer the UCLA 3-item scale, and he actually scores quite low on this scale, 1 point on the 0 to 6 point scale, indicating sometimes he feels left out. And he notes that he has really nice companionship from his cat, which is named Yip Yip. And this actually starts a conversation about his whole social life and how he's been compensating for what's been going on. So I've often found in clinic that these scales, they're helpful screeners, but they're a really nice starting point for what's going on in someone's life. Okay, so now let's turn to social isolation. Social isolation is defined as a complete or near complete lack of contact with society. So it's a quantifiable number of relationships. You can actually count up, how many children does someone have? Are they living alone? Are they married? How often are they seeing their friends? How often are they engaging with community activities? You can imagine that it gets complicated really quickly. And because of that, there are many, many different social isolation scales. But one simple screening tool I've used in clinic is looking back over the last year, who are the people you talked with most often about important things? This is getting at the idea of confidants, or who can you confide in about important things when they come up. And if people have trouble naming anyone or can only name a few people, they may be socially isolated. In the United States, nearly 1 in 5 older adults are socially isolated. This is consistent with global estimates from where we have data. This is a very high number. It might be shocking to many people in the audience. I think of social isolation on a spectrum. And so sometimes people are kind of on the lower end of this, are about 20% of US older adults. People who have really extreme forms of social isolation, who have very little contact at all with society, that affects about 1 in 20 people in the United States, or about 5% of our population. Social isolation has similar health impacts as loneliness, but we think through separate mechanisms. So here is one seminal study published in the Proceedings of the National Academy of Sciences in 2013, which found that social isolation was strongly associated with premature death. And this has since been replicated in a number of studies, including in 2020. When social isolation or social connectedness was compared to many other public health priorities, it was found that it was had a similar or greater association with mortality compared to other leading public health indicators. This is work conducted by Dr. Julianne Holt-Lundstadt, which found that social connection, shown in these top bars, was associated with decreased mortality more strongly than things like smoking, half a pack of cigarettes a day, alcohol consumption, physical activity, obesity, or even air pollution. And this was really one of the studies that brought social connection onto the map and received attention from our US Surgeon General with this tweet shown on the right-hand side. What I found recently is that all areas of medicine are increasingly interested in social isolation. And so nearly every specialty is finding that social isolation impacts downstream health outcomes. So I've put a number of citations on the bottom left-hand corner, which you can take a look at if you're interested. Here is one study that was recently published by colleagues at Yale and University of Maryland. They followed about 1,000 older adults who were previously hospitalized in the intensive care unit, and they followed them for about a year. And they found that for every 1 point increase on a social isolation score, they had a 7% increase in disability count and a 14% increase in mortality. And you can look at the Kaplan-Meier survival curve here on the right, bottom right-hand side. If you see people with the most extreme forms of isolation, that's 6 points, their survival is pretty striking, about a median survival of less than 6 months. So what might be going on here? Social isolation is not necessarily distressing, emotionally distressing to people like loneliness is, but it does have health impacts. So the first is when people are isolated, they don't experience the benefits of socializing, right? They may not be able to go out on a walk with friends. If something troubling comes up, they may not be able to get on the phone and, help ward off depression or anxiety. And when health crises come up, like they're hospitalized or they experience a serious illness, they may lack key sources of support to mitigate the health impacts. They may not have financial support, medical support, caregiving support. I think about this a lot for people at the end of life, or emotional support to help people kind of get through tough times. So coming back to Mr. Smith, we decided to conduct a much more rigorous social history to understand what's going on. And we learned that he lives alone, he is divorced, he has no children, he has no close friends, noting that all of his friends have died. He's unsure of how to use a video device or a smartphone to connect with more distant relatives. He wishes he could volunteer and give back to other veterans. And when we ask if he has a designated power of attorney, he asks if we can be his designated power of attorney, indicating that he has really no emergency contacts. So to summarize here, he's socially isolated and he's occasionally lonely. And so again, people can experience one or the other or even both, but it's important to think about these as related but distinct concepts with separate health mechanisms. Okay, so hopefully I've convinced you all that social isolation and loneliness can be defined and that they have important health impacts. I'm next going to turn to experiences of loneliness and isolation among older adults affected by serious illness. This is really guided by my clinical experiences in palliative care and a subgroup that I wanted to highlight because I think there are unique impacts here. So I was drawn to this topic because of really impactful work conducted by Dr. Karen Steinhauser out of Duke University. She conducted a survey study of seriously ill adults, people who are in the last year of life. She surveyed those patients, caregivers, as well as their clinical teams about priorities that people have at the end of life. And what she found was that individuals and family members cared just as much about their social needs as they cared about physical symptoms, psychological symptoms, and the type of healthcare received. So, for example, people reported that having someone who will listen, sharing time with close friends, being in the presence of family, being able to help others was incredibly important to them, even when they were in the last months of life. And yet, when people are experiencing serious illness, they may be less able to cope with loneliness. When people have that feeling of wanting connection, they may be impacted by significant symptoms from their serious illness. They may be experiencing disability or confinement to their home. They may have fewer people they can reach out to. People may also become more isolated as they approach the end of life, which can impact their quality of life and their healthcare. And so we set out to just get us an understanding of the landscape of loneliness and isolation for people who are seriously ill. So we use the Health and Retirement Study in the United States, which is a national survey of older adults over 50 years old. And we looked at people who had recently died, but answered questions about loneliness and social isolation within 4 years of death. So I'll walk you through this figure. On the right-hand side, you can see on the y-axis the prevalence of loneliness, and on the x-axis is the time before death, and it's broken up into 3-month intervals. So all the way on the left of the x-axis is about 4 years prior to death, and all the way on the right on the x-axis is 3 months prior to death. So what we found was that loneliness was really common. About 2/3 of individuals reported any loneliness, so 1 point or higher on the 0 to 6 point scale. And about one in 5 people reported frequent loneliness. So they reported feeling, 4 points or higher on that 0 to 6 point scale. This was about double the national prevalence in the United States. When we looked at the change over time, we found that it was relatively flat. So over those 4 years, people had a fairly consistent prevalence. Okay, how about social isolation? Again, we found an overall prevalence of about 1 in 5 individuals feeling socially isolated. And as people approach the end of life, social isolation increased in prevalence from about 18% to 27% when they were in the last few months of life. So that was a significant change, and you can see a kind of a gradual uptick over time. Now, you might be thinking, these are pretty similar numbers. How do we know we're not just getting at the same thing? So how can people put into the chat, whether they think loneliness and social isolation commonly co-occur at the end of life? Maybe I'll just pause here. So when we look, oh, sorry, go ahead.
Sorry, just wanted to remind them, please, can you put your answers in the chat and tell us how do you think about that?
Great, thank you. So even if you don't want to put it in the chat, just think about this. Is this something that's co-occurring? When we looked at this, we found that only 5% reported both loneliness and met criteria for being socially isolated. So this was really surprising to us, despite a lot of the literature showing that this was the case. But these experiences are really relatively distinct for people approaching the end of life. So why might this be so common at the end of life? There are a number of losses that people are experiencing as they're aging or approaching the end of life, which can predict loneliness and isolation. These include the death of a spouse, the death or loss of relatives or friends, or changes in living arrangements, which can be quite difficult to replace. Institutionalization, people may be leaving their homes of many, many years to move into the homes of their children, or even to move to nursing homes or assisted living facilities. And of course, they may be having deteriorations in their health, including deteriorating physical health, impairments in their mobility, impairments in vision or hearing, which create barriers to interacting with others, and then just less opportunities for social activity as their health declines. Many of the activities we have in our communities, for example, are not geared towards people who have experienced significant physical or mental health challenges. When we looked at predictors of loneliness and isolation in the last years of life, we found that cognitive impairment was among the strongest predictors. So here's some of our data showing that it was a strong predictor of social isolation, 18% to 26% difference, and frequent loneliness, so a 16% to about a 26% difference. And so this was very interesting to us. And so we decided to look into this topic a little bit more to understand experiences of loneliness and isolation among people with dementia. And what we found, so we did some additional work to look at whether socially isolated older adults experiencing dementia had different patterns of healthcare use. And we found that in general, when people have dementia and they're socially isolated, they tend to fall through the cracks of our healthcare system, at least here in the United States. At the end of life, they tended to have lower use of hospice or supportive services for people in the last 6 months of life. And they also had lower use of end-of-life acute care. So they were less likely to end up in the emergency rooms, less likely to be hospitalized, and less likely to be in the intensive care unit. Now, you might be thinking, Ashwin, is this a good or a bad thing? I thought that less acute care at the end of life is is a good thing. You know, people are less exposed to burdensome healthcare. Maybe they're comfortable at home. I think there are reasons to be concerned actually with this picture. And some of the work done by one of my colleagues, Dr. Elena Portocolone here at UCSF, points to reasons why we should be concerned. She conducted studies of older adults living alone with dementia and found that they're really at risk for falling through the cracks of our system. And this is for two main reasons. The first is that there's a preference of older adults with cognitive impairment to kind of avoid healthcare and social activities, even when they need them. So people will actively avoid healthcare and social activities. They often experience shame or stigma around the cognitive impairment that they're experiencing. And so they'll actively try to conceal the impairment from others. The second problem that they run into is there's a lack of tailored services. In the United States in particular, it's a very fragmented healthcare system. And so it can be difficult to navigate the many different hospital systems, specialists, and care that people are receiving. And that's especially the case as their care becomes complex towards the end of life. Dr. Portocolone provides the example of someone losing their driver's license here in the United States due to cognitive impairment and how that can really isolate people at home and cause problems. So I think we're in a situation where people may be falling through the cracks of our healthcare system and have significant symptoms or healthcare needs that are really unmet. This is the situation of people living alone with dementia. But how about their caregivers or their surrounding family members? We've been interested in the isolating effects of dementia on people's whole family units. And so I've been fortunate to work with Dr. Krista Harrison here at UCSF, who conducts qualitative work with persons with dementia and their caregivers. And what we found is it's an incredibly isolating condition for the entire family. So here's one quote from the study from one of the daughters of someone with dementia who said, "My dad, especially when my mom was gone, was very scared and emotional and labile and easy to trigger. And so a couple of friends came by and got sort of scared off and started to get the feeling like, I'm not helping by being here, so I just won't come. And so very quickly people didn't come. So he was pretty lonely, except for the caregiver, me, and my family. I mean, very few visitors." And this can be incredibly impactful on spouses of persons with dementia. So here's one quote of the wife of a gentleman with dementia who said, "The emotional stress is very debilitating because, as I have always said, you're taking care of someone who's the love of your life. So you're losing that core relationship by becoming a caregiver, but you try to cling to it and they can't respond to it. And it's just this back and forth struggle to make sense of this relationship that you're now basically a nurse for." And spouses also related that when a person with dementia reached kind of the breaking point at home where it was really difficult to provide caregiving support, they often move to an assisted living facility or a nursing home. And that can be an incredibly hard moment for people to deal with. So one spouse said, "It was harder for me than it was for my spouse. Spouse adjusted to the assisted living facility over the course of a few months, but my husband leaving home was one of the saddest, if not the saddest day of my life. And then coping with that, with him still being alive, but not being able to be at home, it was very lonely. It was much more difficult for me being lonely, and I was exhausted for caring for spouse at home." When we actually conducted a national survey of spouses of persons with dementia, and we found that they indeed have higher rates of loneliness and depression, as well as both of those conditions compared to spouses of persons without dementia. So I think when we're thinking about serious illness, it's important not to just consider the experience of the individual experiencing the serious illness, but the entire family unit. Okay, so we've thought a little bit about the unique experiences of older adults with serious illness. Let's now turn to think about how we can support older adults experiencing loneliness and social isolation. This is a really big emerging topic, and so I'd really welcome thoughts from the audience on how to address this, and we can brainstorm together after the session is done as well. Okay, so part of the reason why this is a huge topic in the United States right now is because of a seminal report which was released by the Office of the Surgeon General in May of 2023 called Our Epidemic of Loneliness and Isolation. In this report, Dr. Vivek Murthy calls for national action across 6 different sectors to really make some strides forward on enhancing social connection. This has also become a global priority. Actually, just a few days ago, on November 15th, the WHO released a report that they're leading a commission on social connection, which is really aimed at catalyzing global leadership in this area, including data collection, interventions, and thinking about global collaboration and how we address these needs. So this is a really big area right now. So I'll share with you the approach I've been using in my clinic to address this topic, because this is an area where we're still waiting for robust evidence base to guide us in terms of interventions. But because of the suffering that this causes in real time, I think there's a lot of things that we can do both on an individual level as well as a public health level as we await that evidence base. So the first is just identifying loneliness and isolation. It's very common, as you all have seen, and we have reasonable scales that can get at these concepts. Loneliness being the UCLA 3-item questionnaire, or social isolation. There's a number of scales. The Berkman-Symes Social Network Index, for example, is a 5-item questionnaire that gets at these concepts. There's also just clinical conversations we can use. I've, in my clinic, for example, said, I've noticed that many people have felt lonely during the COVID-19 pandemic. Is that something that you've been experiencing? Or how often have you felt lonely? For social isolation, I'll ask, who can you talk to about important matters like your health? Or do you need help connecting with others? These are simple questions, and it can really help be a nice starting point for these topics. If people identify as lonely or being socially isolated, I take a step back and try to identify potential causes and help process emotions. Experiencing loneliness or isolation can be an incredibly emotionally distressing experience, or can be tied to significant life events. People may have just lost their spouse. They may have been diagnosed with a new serious illness. Maybe they're experiencing the changes in their living situations, or something has changed quite a bit from what they were used to. So it takes some time to provide space for them to discuss what's going on. One helpful palliative care tool for addressing emotion is this NURSE framework, which stands for name, understand, respect, support, and explore. So I might say, this sounds like you've been going through a lot. Can you tell me a little bit more about what's been making you feel lonely? Or would it be helpful if we talk more about what you've been going through, and maybe we can explore some different ways that I can support you? Importantly, I usually ask people if they want help in addressing their challenges. These are really personal topics, and not everybody wants their clinicians or their medical teams involved in their social lives. When people do want support in addressing these needs, I take an individualized approach to interventions. So I try to address modifiable clinical factors, and I think about social interventions that might help. So clinical factors might be things like vision and hearing, their functional needs. Even incontinence is incredibly strong predictor of loneliness and isolation. So the intervention here might be as simple as providing a hearing aid so that people can participate in social activities. It might be helping to address incontinence so that they're not feeling so anxious about going out in social situations or traveling long distances. Social interventions involve things like providing more social support, enhancing interactions, or addressing maladaptive cognition, or that kind of drive to avoid social situations because people have lost social skills or have had poor social experiences in the past. So here's some example of social interventions. In San Francisco area, we've been working a lot with a senior center that provides peer support programs. They match older adults with similarly aged and similar background peers. One participant in our program said, it's just like having a friendship. A lot of folks I don't really want to be friends with. It's nice to have someone you can talk to who doesn't look down on you, who doesn't find fault in anything you say or do, and just looks at you as a person. And we found that this program reduced barriers to socializing over about a 24-month period, shown on the right-hand side. There are a number of programs that have come up, especially since the pandemic. In the United States, there's the Institute on Aging Friendship Line, which is available nationally. These are people can call in and just have a friendly voice on the other side to help talk through anything they need. The VA has the Compassionate Contact Corps, and there's actually been a national drive by the Administration for Community Living to create a repository of evidence-based interventions to improve social connection. And that's at the Commit to Connect website that you can all check out. In serious illness, I think there's a number of unique ways that we can support people. We start with just trying to prioritize and preserve existing social connections, which can often be disrupted by serious illness, right? When people, especially family members, shift from being a family member to being a caregiver, that can really cause changes in the adequacy of someone's social life, going both ways. We saw that with the case of dementia. This can actually happen across many serious illnesses. So really trying to preserve those roles can be a good starting point. We can think about new social connections, right? Support groups, pets, peer-based support. Technology-based solutions are often helpful, although I tried to suggest that they not be a substitute for human interaction. Interdisciplinary teams can be really helpful here. Dignity therapy is this idea of sharing people's legacies or life stories with others to try to preserve meaning even as people are approaching the end of life. Art therapy, music therapy can be really important. And of course, we need to consider the unique needs of each serious illness. Okay, maybe just a quick word on in-person versus virtual interactions. Right now, we're interacting virtually. Is that a good thing? I remember I went to a conference for the first time after a pandemic, and everybody was like, we've only seen you on screen, and you're shorter than I expected. Not exactly what you want to hear when you meet someone for the first time. Yeah, how do we reconcile in-person versus virtual interactions? Is one better than the other? Should we be striking a balance in a certain way? Well, the jury is out. You know, we don't quite know yet, and a lot of this data is still emerging. But here's one study that was conducted by colleagues at University of Chicago, where they compared virtual interaction to in-person interaction during the pandemic. And you can see that when people had decreased in-person contact, shown in this top row, they had reduced happiness and higher rates of depression and loneliness, and increased calls over the phone, through messaging, through video calls, was not quite enough to offset that. And I'll actually draw your attention to the bottom right-hand corner of these graphs, which showed that decreased in-person friend contact was really associated with higher levels of loneliness that were not offset by this virtual interactions. So we're tending to move towards a place where in-person interactions may be a little bit more beneficial to health than virtual interactions. Either way, I think we need to acknowledge that there are trade-offs to health when we purely consider in-person restrictions to the detriment of other domains of health. In the hospital or in nursing homes, there can be incredible distress from visitor restrictions when people are limited from seeing their loved ones who are seriously ill. So we need to be thinking about the health impacts there, especially over long term. There's also a lot of research that shows that there's benefits of physical touch, and there can be increased cognitive stimulation when people are in person. So all of this to say, there are certainly reasons why we can't interact in person in certain situations, but we need to consider these trade-offs. Okay, the fourth step here is we need to think about related medical needs. People who are socially isolated may not have emergency contacts or advanced care planning documents. There may be co-occurring psychosocial needs like poverty, food insecurity, or decreased access to technology, that we can use these needs as a window into addressing other social determinants of health. And of course, we need to think about the mental and psychological distress that people can experience. Ultimately, in the US, we really need policy changes that incentivize addressing the social determinants of health. We're still working a lot on this topic, and I think we're making some important gains. And I think this needs to occur at a global level as well. And I'd be interested to hear your thoughts on whether we should be prioritizing this issue and at what level we should be doing that. Okay, so with that, our key takeaways for today: loneliness and social isolation are key measures of social well-being. They're linked to health outcomes, quality of life, and healthcare use, especially among people with serious illness. And enhancing social connection represents an important opportunity to improve the health and well-being of our patients. And I look forward to your thoughts. I'm so grateful to many of my mentors as well as my lab that helps move this work forward. And I'd love to hear questions or comments, and feel free to contact me even outside of this talk. Thank you.
Well, thank you so much, really, for delivering such an outstanding and valuable presentations. Actually, I think while you're presenting, all of us related, because we all know someone who was an elderly or currently an elderly, or someone who lost someone. So it was so relatable. I shed some tears actually remembering my dad, because he went through this stage as well. So we all been affected by that. And that make me also remember the pledge that was released by the WHO in the decade of healthy aging, where they all pledged that no one should be left behind, and that every human being will have the opportunity to fulfill their potential in dignity and equality. And that's why I would like to thank you really for shedding the light on such an important public health matters. It may not be of high on the agenda of the stakeholders at this country at this stage, because we know that UAE is still a young country. Actually, we're celebrating our 52 Independent Day in a couple of days, but it is an issue that should be back onto the agenda. So I can talk with you for hours, but it's actually the right of our participants. I can see a lot of the questions here. They are thanking you for such a great presentations. And we have a questions from Izzy. She's referring to the cultural aspects of loneliness. So she's saying, is loneliness more common in immigrant, displaced persons? And are the gender-based difference when scoring the loneliness in general during your practice?
Yeah, these are great questions. For immigrant communities, it kind of depends. So in the United States, for example, there are many different immigrant communities. And when they come in, if they can actually, if there's an existing immigrant community in the States that they can relate to, it can actually be a buffer against loneliness and really help to preserve some of their social identity. But as you know, when immigrants leave, they leave a lot of the prior status that they've had in their country. There may be language barriers. They may be leaving because there's some type of situation in their home country, under duress, because of a lack of economic opportunities in their prior country. And so all of those things can be strong indicators of loneliness, as well as isolation. From a medical standpoint, I think a lot about immigrant communities or recent immigrants as having fewer social contacts in the receiving country, which can also create a number of barriers, especially when health crises like the pandemic arise. So I think we need to think about immigrant communities as a group potentially at risk, but really assess their individual needs. From a gender situation, it's interesting data. Many women for example, report higher rates of loneliness compared to men. But men tend to be more socially isolated than women. So it can go both ways for this. Again, I think we need to think carefully about how these concepts are related but distinct.
Yeah, that's a great answer. So Izzy is really interested in the topic. So she asked another questions, whether you can relate resilience to loneliness. So how can you relate that?
Yeah, another great question. Resilience is getting a lot of attention right now because there are many different domains. We can think about physical resilience to stressors. We can think about cognitive resilience, and I think social and psychological resilience is incredibly important here. And when we experience stressors in our life, drawing on our social resources can help to provide a buffer to those stressors. And so loneliness, this idea that your social life is, or your social situation is inadequate, might be an indicator that, you may not be able to draw on those social resources when you need them. So I think it's important to consider that in the concept of resilience overall. And still a lot of research to be done in that space.
Yeah, completely right. So we have another questions, whether and as you stated, that social isolation is very much influenced by culture. So is there any data during your research, and I believe we discussed that earlier, on social isolation in the Middle East?
Yeah, gosh, I had not seen any data in the Middle East. That's not because I didn't look. Really trying to look at this data, and I think it's this is a call to action, really, that we should be gathering more data, and because that's really fundamentally can drive more research in this space for addressing these needs. There are ways that potentially you could get at this from health records, from publicly available data, and so I'd be happy to talk with people about that. Perhaps outside of the session. But yeah, I unfortunately have not seen any data on this. There is a lot of work that suggests that living in multi-generational households can reduce social isolation, that there are cultural differences between kind of more individualistic nations versus more communal nations. Population density is an issue too, right? Urban versus rural areas. So there's a lot that I think we can draw on, but we ultimately need more data.
Yeah, I would do agree. So going back to Asma, she's saying, thank you so much for such a detailed input. And since we were discussing the delving in the data that you did, so did you come across any specific biomarkers which were high in subjects who reported higher level of isolations? So some kind of biological biomarkers that you can, yeah.
Yeah. So for loneliness, there tends to be more biomarkers that are associated with it. And I think that's because, it's emotional distress. It can lead to this stress, these physiologic stress pathways, the HPA axis, for example. And so there is some data that shows higher rates of C-reactive protein that have related this to EBV reactivation, that have shown kind of inflammatory pathways that are impacted, including like the IL-6 and IL-2. So there is some data on the biological pathways that are impacted. We're still learning more about some of the other pathways, like its impact on cognitive health, on cardiovascular outcomes. But I think it probably all comes back to these stress pathways.
Yeah. Yes, you're right. So I can see two questions in the same domain asking about the role of artificial intelligence and robots to offer some emotional support for elderly. Like example, there was a study conducted in Japan about this one. So what are your thoughts about the use of such technology for elderly?
Yeah, great question. Huge topic right now. I'm cautiously optimistic that there is a role. I think AI, social companion robots, robotic pets can serve a role, especially when they're helping to facilitate social interaction. I've seen some of these companion robots, for example, help call rides for people so that they can get to a community activity, or they'll ask people, "Oh, do you want to talk to your daughter right now?" That's great. Even for robotic pets for older adults, they may not be able to take out a pet for a walk, or they may not be able to clean up after a pet. But a robotic pet might provide some level of companionship that's comforting. So, maybe there's a role. I hesitate, though, when these technologies are used as a substitute for human interaction, because I think there is a potential for really lost opportunity here to enhance people's lives. And I think we have to get back to the basics to some degree, and not overly rely on these technologies for something that's so basic to who we are.
So actually, we don't want the time to get over, because we're really having a very dynamic interactions. And I'm so thankful for all the people who are attending the webinar today. Is actually our master students, PhD students, clerkship students, faculty, and esteemed guests. And our network is really supporting. Izzy is still interested in asking you if you have any evidence that homes for elderly decreases loneliness. So did you come up with any studies about that?
Yeah, we're actually in the process of looking at the impact of a transition to nursing home on people's social interactions. I think what we're finding is that when people enter homes, these nursing homes, and they're really debilitated, right? They have a lot of functional disability. They've been really limited in social interaction. That going into these homes can be really helpful, because suddenly you're in an environment that's tailored towards addressing your needs, including your social needs. Of course, the pandemic kind of upended all of that, but in general, nursing homes can be helpful for people who have disabilities at baseline. Now, for people who are entering nursing homes who had really active social lives, it might be a step down. It might be a more restrictive environment to maintaining the social interactions that they previously had. So I think it's a trade-off here, and but I don't think it's a purely negative story. I think it's more mixed.
Yes. There's a lot of questions. Professor Muayin is asking that we need to look at the difference in social cultural values on the issue, and maybe he's interested in conducting a research with you. So being the webinar coordinators, I'm going to take my positions and going to ask you to come again and present on this topic, because as you can see, it's a very dynamic project and many questions are actually arising, and it is very interesting. But for the sake of time, I have to conclude today's webinar, and I really would like to thank you so much, Dr. Kotwal, for accepting our invitations, actually, and for presenting such an early morning for you. I know that I hope that you had a good start of the day. And at the same time, if you allow me, I would like to ask as well to thank everyone who is involved in making this webinar actually possible, including the management of the College of Medicines and the United Arab Emirates University, and special thanks to Prof. Michael Grivna, the director of the Institute of Public Health, who is here with us here today and is always supporting all our webinars and all our initiatives. So thank you so much, Prof. Michael. Thanks to Mr. Assager for the technical support. Special thanks to all the IPH team, Dr. Affat, Mr. Amino, Ms. Bayan, for all their support, and Mr. Ismail, Ms. Khadija Deblouchi, and Ms. Maryam Niadi from the Dean Office for supporting us in spreading the word about our webinars, and a heartfelt thanks to our audience for their active participations actually in this webinar and all our webinars. And please remember to fill the evaluation form so you can get the CME certificates, and we'd love to hear your opinion about this presentation so we can improve. And stay updated on our social media account UAEU at IPH, in which we post all our informations and webinars and publications. And this webinar is going to be uploaded on our YouTube channel, Institute of Public Health, CMHS. And this is the Twitter account of Dr. Ashwin. Please feel free to contact him and keep these conversations going. And looking forward to our last webinar of this year, which is on a special day, 12/12/2023. And everybody stay safe and goodbye. And thank you so much, Dr. Kotwal, again, for accepting our invitation. This is a real honor and pleasure. Thank you all.
Thank you, everyone.
Thank you.